Hello, everyone. Today I'm going to share some information about musculoskeletal trauma in general and bone fractures in particular. As nurses, we're not expected to diagnose different types of fractures, but understanding the damage that goes along with different types helps us anticipate the needs of our patients. So, what are some things that nearly all fracture types have in common? Bone fractures are damage to the structural and protective framework of the body, and as such, even though we think of them as broken bones, there's damage to the soft tissues. There's going to be pain, there is bleeding to one extent or another, and to repair all this damage is going to require extra nutritional support. What are some nursing considerations to keep in mind? Think about what bones do, the long bones, for example. Tendons attach muscles to the bones, and the muscles contract to put force to move the body at the joints. Think about the fracture pictured here. Imagine the quadriceps stretching down the front of this femur. It's meant to hold each end and contract to use the strength of this femur to raise the lower leg. So if it's pulling against this broken bone instead of an intact one, that force is likely to pull the two pieces toward one another. And given the angle of this fracture, they're going to slide out of alignment. Natural bone is smooth. This bone is not smooth at all. It's very sharp. So the pieces, as they move, they're going to be cutting and slicing and causing pain and soft tissue damage and bleeding in that muscle. So the left of bang thinking here is that immobilizing is critical to prevent damage. That immobilization could be on the outside with a cast or on the inside with pins and plates and screws, depending on where the fracture is and how much strain is on that area. If your patient has fractures with immobilization, you're going to be thinking about comfort, inflammation, and preventing further injury, keeping the cast intact that's clean and dry, promoting bone healing, and watching for infection. Think also about the bones that frame and protect vital structures like the pelvic bones, the ribs, the skull. Their protective abilities are compromised now. Ribs need to be able to move to facilitate breathing. If your patient has several rib fractures, think about what can happen to the lungs with inadequate chest rise and fall. Think about skull fractures with this potential for CSF leak. Or if there's bruising to the brain itself, swelling. Think about all the organs the pelvis protects. So if there's a pelvic fracture, what is at risk there? Be thinking about how the injury happened and what else might have been injured in that incident. Think about what may be damaged as a result of loss of the skeleton's structural integrity. What if you can't immobilize? There are some bone fractures that cannot be. Here's an example. This is a proximal humerus fracture. I had one of these. It's so high up on the arm that there's nothing to cast, nothing to hold on to. Mine happened when I was about in fourth grade on a field trip, and the science teacher who was our chaperone wanted to be a hero. He thought I had a shoulder dislocation, and he really, really wanted to just pull on that arm until it went back into place. Thankfully, nobody let him experiment on me. And you can see how that would have turned out if he had been allowed to try. Anyway, when I finally got to the emergency room, they took the x-rays, diagnosed me, and all they did was wrap my arm close to my chest with a wide ace bandage. That was for several days. And after that, they gave me a sling. So no cast, just trusted a fourth grader to hold her arm still in a sling. It had to heal on its own. So the left of bang thinking here in a fracture that can't be immobilized is how you facilitate your patient's ADLs safely so this bone can heal. Think about the tugging forces that can be exerted by things like dressing and undressing. Think about how the patient is going to be positioning for sleep. You know how important it is for the patient to get sleep to heal. How are we going to manage that? What kind of a sleeping position? What kind of pillows? Recliner? What's it going to be? And putting a child in a recliner for the night is going to be interesting too. So what can you expect in your patient with a fracture? More than anything, expect pain. The patient has movement of the bone where there has never been a joint before and should never be one. So there's going to be soreness. Then think about how this happened. If the fracture is the result of a blow, like a fall, or maybe banging around inside a car that got hit by another car, there's going to be damage from the impact, even not even considering the broken bone. Even if the fracture is not displaced, everything's back where it belongs, there was motion during the injury in directions that were never meant to move. This illustration is of a green stick fracture, which little kids get all the time because their bones are so flexible. The bone actually bends and then it goes back into place. So it's an incomplete fracture. You can see how this still causes soft tissue damage because the arm was never meant to bend there. So be left to bang by planning on pain. Promote NSAIDs on schedule. If they need opiates and it's prescribed, encourage that too. Know that the NSAIDs are going to make your patient much less uncomfortable, help with swelling, promote comfort while it's healing. Help the family understand why this thing hurts, even if, well, he's in a cast now, everything should be fine. Well, let's explain that to them so they understand, but also so they're not overly fearful. So bruising is bleeding. So treat your bruises, use cold compresses. More critically, if your patient's anticoagulated, you're going to be needing to be alert for whether that bleeding is going to stop appropriately. Fractures of bones that have marrow are another story entirely. There you can have not only bleeding, but fat emboli as that nice fat bone marrow gets forced into the bloodstream. You can also have loss of the body's ability to grow new blood cells, which it really needs right now as it's healing this fracture and all the related injuries. It's even possible that your patient may need a transfusion if it's that bad. Anyway, as the nurse, you can watch for signs of any of these and catch them early. If your patient is a child or a baby, think about growth plates. That's near the ends of the long bones where new bone is being created. Bones lengthen at the ends, of course. And in children, the growth plates some bones are all growth plate. So if you have damage to the growth plate in a child, it has serious long-term risks for inhibiting growth. And the child can end up with a leg length or limb length discrepancy, an arm or a leg. I have heard of children who had an injury to the radial growth plate and not the humeral, and it ended up with a forearm that was twisted because one of those bones could grow and the other one could not. I have a personal example here too. My son had an injury when he was about 2. He was running around with a piece of metal in his mouth. He tripped and fell on the garage floor and rammed that up to the roof of his mouth. It didn't go through as I thought, but it did heal. I thought it healed fine. But when he was a teenager and we went to get his braces on, they did full head panoramic x-rays, very thorough, and they found that half of the roof of his mouth had not grown like the other half. You couldn't tell by looking at him, but you could tell on the x-rays that metal rod that he rammed up there had damaged the bone as it was growing. So only half of his mouth grew as it was supposed to. So as your patient's healing, what is he going to need? He's going to need the building blocks to rebuild the bone and the soft tissue too, of course. That means a good diet, including calcium and vitamins D and K for bone healing, vitamin C and zinc for soft tissue healing, and most of all, high quality protein for everything. This is a good time to encourage reduction of caffeine. Caffeine can interfere with calcium absorption, especially early on in the bone healing stage. And if your patient's a smoker, this would be a great time to discuss working on that, reducing or stopping, because it will pay off in healing time. If your patient is casted, it's likely that there's going to be muscle atrophy as time passes. That means because those muscles are not getting exercise unless you make an effort at it. So they're going to atrophy. And the cast that fit well at the beginning of this episode may be too loose a few weeks later. You may actually have to have the patient recasted if the healing is not complete. You don't want to have a lot of motion inside there. If possible, advocate for your patient receiving physical therapy even while healing, because studies show carefully directed physical therapy, exercise, can minimize muscle atrophy and shorten rehab time once the fracture's healed. While we're talking about casts, if any of you have ever had a cast, remember how they tell you no matter how badly it itches, don't stick anything down there? And is there any of you who've ever actually obeyed that? Of course not. It's horrible itching. It's intolerable. So just count on the fact your patient's going to be sticking coat hangers and hairbrushes and yardsticks down that cast, digging away, trying to get to that ferocious itch. And if that coat hanger nicks the skin, now you have an open wound in an area that you cannot disinfect. So high risk of infection. Plan ahead, watch for that. Teach your patient how to assess for things like heat on the cast or funny smells, anything. They'll know. They'll be able to tell. And because they need to speak up because it's going to be critical to get that cast off quickly and treat it. So all this is just to say it's our job to support healing for our patients and anticipate the things that may go wrong so we can catch them early and head off problems.